Thanks for joining, everyone. Just before I start, throughout my slides, I will be using the term Aboriginal. Within Western Australia, the term Aboriginal is used in preference to Aboriginal and Torres Strait Islander people, just in recognition that the Aboriginal people are the original inhabitants of Western Australia. So today I'll be talking about the WA Aboriginal immunisation schedule and in regards to the additionals and why are there difference and having a yarn to families. So attached is the recently new WA Aboriginal immunisation schedule that the Department of Health released after I know a pretty lengthy community and stakeholder consultation. So it shows all the immunisations that are recommended for Aboriginal people, including the additional vaccines for WA. For Aboriginal children, these additional vaccines are for Hep A, influenza, meningococcal disease, pneumococcal disease. And then for Aboriginal adults, these additional vaccines are for Hep B, influenza, pneumococcal disease, and zoster. So I think one of the recent ones when I come on board was in 2020, they introduced meningococcal B vaccine for childhood immunisations for any Aboriginal child under 2 was eligible to catch up. This is a really important mark. I know Adelaide has had it for some time and has seen the reduced rates in meningococcal B. So you may ask why do Aboriginal people receive the different vaccines? So we know after European colonisation, Aboriginal people experience infectious disease at epidemic rates with very high morbidity and mortality rate. And we're still feeling the impacts of that today. So as you can see, I've just, it's from the DWA website, the difference in rates. I've got it circled for influenza. So this is just one of the big ones that we see a lot of, and you will as well in GP land. So in 2003, there was 2,246 influenza notifications. That rate is at a really large more rate than non-Aboriginal people. So we now make up 4% of the population. It's just not acceptable. So sometimes people, you also hear terms, I feel like, that, you know, that we live in overcrowding or in a poverty-like state. I don't really like those terms. I think when we're speaking about the different vaccines, it's making sure we recognise that Aboriginal families normally come from a collectivist culture, meaning we put others before ourselves. We come from a kinship with family and community are so important to us, which means we see a lot of our what is known as an extended family a lot more. Living in large households or having family over, especially within the winter times, is very common for us. And it's such a, you know, we're raised by our community, not just our mum and dad, or we see just a sister and our mum and dad and that's it. So I think that's so important to recognise because we're around and very close to a lot more people than others. I think I'll just go on to yarning to families as well. Just a few tips. There is some resources that I'm sure can be shared. So it's so important to make sure Aboriginal families are aware of the additional vaccines that are available so they can make an informed decision. So it's really important to ask all of your patients, do they or their child identify as Aboriginal or Torres Strait Islander origin, because then that way you know you can have that conversation. When yarning to families on why there are additional use, let them know that we're lucky to have that strong kinship that I previously mentioned, and also using that clinical yarning model. So it's culturally appropriate. It's a patient-centered form of communication that creates an opportunity for that relaxed conversation. And you can bring in about immunisation or having that opportunistic vaccination. I think clinical yarning improves outcomes for both patients and practitioners. And of course, you can adapt it to all of your clinical yarning models. And I will pass it back.
So I'm Paul Leffler. I'm a senior medical advisor and the acting director of communicable disease control at the moment. I've no, you can still see the screen because I can't see any of you. I'm just reconfirming before I move on.
Yep, you're good to go, Paul. Yep.
So I have no stock holdings, no pharmaceutical affiliations, and no pharmaceutical payments in my background. And I think that's important to say because I'm going to talk about products that we work to bring into the state, but it's not influenced by financial interests whatsoever. So as you probably are all aware, we started a nirsevimab program in 2024. And nirsevimab is a monoclonal antibody that you can give to young infants to protect them from respiratory syncytial virus. And it's different than a vaccine because it doesn't stimulate their immune system to cause antibodies. It's actually the antibodies are created in the laboratory and then provided to the child. And the good thing about that is they offer almost immediate protection. You have detectable antibodies within 8 hours, and you have peak antibody concentrations circulating within 6 days. So they're really effective at getting protection quickly, which is important because RSV is so infectious that 65% of infants will get infected in their first year of life, and about 90% will be or more will be infected in their second year of life. So we have our program, our rollout here is trying to reach all infants born on or after October 1st of 2023 through the end of RSV season. So we started a catch-up program because we started on April 2nd. So we're going back to kids that were roughly 6 months of age and moving all the way through RSV season. And then it's really important that the second group there be that we actually get children as they're born at the birthing hospital or as soon as we possibly can thereafter, because these children, these little infants are really high risk when they come out in RSV season of getting infected and are more likely to be hospitalized. And there is evidence to say that RSV infection early in life ultimately is associated with development of childhood asthma by 5 years of age. So that's kids that are entering their first RSV season. Then the other two groups we have are children entering their second RSV season. And there are some children with medical risk conditions that place them at a very high risk of having RSV, severe RSV illness and being hospitalized, neurologic, respiratory, cardiac conditions primarily. And we got advice on which children should be included in those conditions from Children's Hospital, from the pediatrician specialists over there. And they provided us with a list of children that are at increased risk in their second season. And then fourth on our list, you'll see all Aboriginal children entering their second RSV season. And you might say, why is that? Why would we make that decision? Because these children don't necessarily have medical risk factors. I mean, some of them might, but as a cohort, generally not. So why would we include them? And I'm a big believer that more medicine is not necessarily better. So you really should have data to back up your decisions about what you want to do to make the best decisions. So what do the data show about RSV in Aboriginal children in WA? As Naomi just showed you, the differential in rates for influenza and RSV as a whole. I'm going to break that down a little bit into the young children that are really possibly age eligible for RSV in Western Australia. So on this slide, what you see is we have 2 years worth of data, 2022 and 2023. Those are the only 2 full years for which RSV was a notifiable condition in Western Australia. So I'm limited to those 2 years, but the consistency of what I'll talk about suggests that that's not an issue. And then in each of those years, you can see on the left-hand side, there's 2 age groups. There's kids under 12 months of age, under a year of age, and then there's below that is children that are basically 1 to less than 2 years of age, and that's the first one is kids entering their first RSV season. Essentially, the second white line is children entering their second RSV season. And then as we go to the columns, we have them broken down by Aboriginal children and non-Aboriginal children. The first row is a population. We won't spend much time on that, but it gives you an understanding of how robust the figures are. The second column in each of those groups is how many hospitalizations there were for RSV illness in each of those years. But more importantly is the third column, which is the rate of hospitalizations in each of those age groups in each of those years by whether they were Aboriginal or non-Aboriginal children. And so what I'm talking about is we're comparing these two columns, looking at these two columns, and to compare non-Aboriginal and Aboriginal children, or the hospitalization rates in those groups. And what you see, if you have Aboriginal children first and you divide that by the rate of non-Aboriginal children, essentially in every year in these very young kids, Aboriginal children have approximately 3 to 4 times the rate of hospitalization as non-Aboriginal children. So that's why Aboriginal children are a real priority for us to try and get them protected against RSV, because the impact is even greater. It's substantial, it's significant in non-Aboriginal children. It's just even greater in Aboriginal children. But why would we include kids in their second year of life, when we look at this, but Aboriginal children in their second year of life, but not non-Aboriginal children in their second year of life? And for that, I want to have you look at these two figures. This is the rate, as we just saw, of hospitalizations in kids entering their second RSV season if you're Aboriginal there, and this is the rate for kids entering their first RSV season for non-Aboriginal children. And what you can see is they're pretty similar, right? About 300 per 10,000 hospitalizations in each of those groups. So if you're offering it to every non-Aboriginal or every child entering their first season, but the rate of hospitalization for Aboriginal children entering their second season is just as high, it doesn't make sense not to offer it to them and protect them as well. So that was the discussion we had. It's reflected in other places in North America. They offer it to Native Americans and Alaskan Natives in the second year of life. And what we did, because I do think it's very important to have consultation before one makes these types of decisions. We took this to the clinical leadership group of ACWA and asked them for their guidance based on these data, and they were supportive of us proceeding with including Aboriginal children going into their second RSV season in the eligibility criteria for nirsevimab. So how are we doing with the program overall? Well, this is data that's current as of yesterday. As you can see, overall in WA, we've had 18,004 kids receive nirsevimab so far through 1,000 different providers. I also think that's important. It shows the huge amount of support we've had from the program. And I'm very pleased with 18,000 children. Data from Europe would indicate that for every 25 immunizations that are done, nirsevimab immunizations in infants, you prevent 1 hospitalization. So it comes out to be 720 infant hospitalizations we should be preventing this year in WA this winter alone overall. But let's look at Aboriginal children specifically, and what we see there is we have 1,809 children, Aboriginal children who have received nirsevimab through 310 providers. And that actually, given as Naomi just said, Aboriginal individuals are 4% of the population. Well, that's 10% of the nirsevimab doses that have been given out, which is good, but we could do better, as I'm going to show you in the following slides. So those numbers there, how does that shape up to be coverage? So coverage for all children in the catch-up cohort, that's kids entering their first RSV season in WA, is currently 62%. And I'm pretty happy with that, given it's a brand new program, brand new medicine, and it required tweaking systems that we already had to make this possible, including really getting the hospitals to come on board, which they have done in a big way. Because if we look at the newborn cohort, that's kids born since May 1st who were eligible to receive it in a hospital. We're talking 82.7% right now, which is fantastic coverage because, as I mentioned, those kids are even all children in their first year of life are at risk, and these children are just at the highest risk. So what about Aboriginal children that are entering their first RSV season? And what we see there is we have 57% coverage. And you will note that that's 5 percentage points lower than all children together. But it's pretty good. And I'd like to see it go higher, however. I'd like to see absolute parity or better. But it does suggest that there's good uptake in access for Aboriginal children. But the issue is the Aboriginal children that are eligible as they enter their second RSV season. And for that, the coverage is only 22% right now, 22.4%. So this is rather disappointing because, as we saw, they have hospitalization rates that are akin to children entering their first RSV season, and yet we seem to be doing a less than optimal job in getting them protected going forward. Now, is it too late to immunize? For the providers that are listening right now, is it too late? RSV season has started in Western Australia, but these are data that are available on our website for every notifiable condition. The link is down there if you haven't been there before. It's interesting to look around, and you can see RSV season for the 2 years that it was fully notifiable, 2023 and 2022. You can see that it's 2023 and 2024. You can see that we have those big peaks coming up. And when you look at 2024, it looks like it's falling off right at the end. But that's July, and we're not even halfway through July as far as the data goes because there's a data lag. So right now in 2024, we're just starting to see the spike we're going to get. And I imagine that graph is going to play out just like, and I misspoke before, it's 2022 and 2023, those years. But I imagine it's going to play out just like that with this, the peak. The biggest part of our peak is left to come this winter. So not too late to get all children, but particularly Aboriginal children, as they are at slightly higher risk to get them immunized. And I'll close with this slide. It came out pretty early in the campaign from the WA Country Health Service of this mother who had chosen to immunize her brand new baby. I just think it's a gorgeous shot. I actually sent this photograph to pediatricians I know in the United States, and one of them texted me back that she got teary when she saw it, just because you can see the pride in mom's face and the beauty of a brand new baby being protected from a serious disease. And with that, I will close off, and hopefully I'll be able to log off sharing better than I logged on. All right, if I stop sharing?
Yep, you stop sharing. Thank you.
Cheers.
Thank you, Professor Paul. Now up next, we've got Brooke McMahon, who's going to be speaking about COVID. So Brooke's worked for WAFA for just over 4 years in a number of roles. So some of them include primary care navigator, training coordinator for the mental health tool, IRDST, and in quality improvement. Previous to this, she's had 15 years of experience in general practice management in the northern suburbs of Perth. So over to you, Brooke.
Thank you very much, Michelle. I appreciate that. So my name's Brooke McMahon, and I'm one of the project officers in the COVID vaccination space at the moment, working alongside Rachel Brettig, who is another project officer, and we're led by Jen Burns. So last month, we officially launched our primary care vaccination support program for COVID. And in the 4 weeks that we've been live, we're working with about 30 organisations across Western Australia to ensure the equitable access to COVID vaccinations for all Western Australians, but with a focus of the vulnerable community, and that obviously includes Aboriginal and Torres Strait Islander people. We're getting some great uptake, and I just wanted to share some examples of this work that we've been doing. So in collaboration with the City of Albany, We managed to fund an event that they were working with, and they were working with the homeless population in Albany. We were able to help fund the hire of a marquee, a vaccination esky, hand sanitizer, water, and some consumables like food and snacks for people. And there was a great success with that event. We're also planning to do another one in December with them. Another clinic that we've helped support is working with the Shire of Mundaring and some pharmacies in the area, and they were able to go to local Aboriginal schools and organisations and assist with any overdue vaccinations, flu vaccinations for the children. And we were also able to assist with getting some COVID vaccinations to the parents and families and friends, as well as anyone else eligible at those events. And again, we had some great success. I do also want to mention part of the program is our non-Medicare vaccination reimbursement for COVID. So if there's any patients out there that don't have access to Medicare, we can reimburse the administrator or the organisation the equivalent to the MBS item number for that. So on this slide, we also have some information about co-administration for influenza and COVID. That's quite timely at the moment. And there's some specific resources for Aboriginal and Torres Strait Islander people at the bottom of the slide there. So please reach out to us if you would like to be part of the program, if you have some ideas, if you have a really high vulnerable community in your organisation, we are here to help. And the email address is gpvaccination@waffa.org.au. And yeah, I'm happy to take any questions, or if you need any further assistance, I'm here. But I'll hand back to Michelle, and that's me. Thank you.
Thank you, Brooke. Up next, we've got Joe Staniszewski. So he's a quality improvement coach for Perth's Northwest. They provide support for practice staff around planning, implementing, and evaluating quality improvement activities for accreditation and for improving population health. They are a nurse by trade and have a strong passion for sexual health, LGBTQIA+ health, and Aboriginal and Torres Strait Islander healthcare. So I hand over to you, Joe.
All right, thank you. So hi, everyone. I'm going to be talking about how you can undertake quality improvement activities that you practice around Aboriginal immunisations. And I'm just going to warn you all, I've broken that golden rule of PowerPoint slides, so they may be a little bit busy, but just know that you don't need to read the slides word for word, and they're there for you to reference after the webinar. So you might already know this, but quality improvement is the process of regularly reviewing and refining your practice systems, structures, clinical care, all to improve patient outcomes and practice efficiency. And this is underpinned by that quintuple aim for healthcare improvement, which you can see on the slide. But what many people don't know is that we're doing quality improvement in our everyday work. Quality improvement can involve changing our personal practice as a clinician to become more efficient in our care, or to be more knowledgeable in a certain area to align with our practice with best practice guidelines. But quality improvement can also be on a larger scale, which involves like changing and streamlining clinical processes and policies, or like implementing interventions that improve health outcomes for a group of people. One thing we don't necessarily do all the time or consistently is document that quality improvement work. And this can be because we're time poor, we don't have the templates available, or we just like to get on with the work, or we have competing priorities. So why should we document quality improvement activities? Well, for general practice accreditation purposes, there has to be some sort of paper trail for us into undertaking these activities, and accreditors may find it a red flag if you don't have any evidence of changes or improvements in a general practice environment within the past 3 years. It also means that if new people come into your organisation and want to know about the changes that have occurred in the past few years, or if they want to take over quality improvement activities that are underway, then they can refer to that quality improvement documentation. So on this slide, you can see the most common ways of documenting quality improvement activities by listing your individual activities in a quality improvement register, or you can hash out a larger quality improvement activity as a PDSA or a plan, do, study, act cycle. And you might find the PDSA looks quite intimidating, but it's just a methodical way of testing change and analysing results along the way, as well as reviewing your results at the end of the test to see if things have actually improved or whether it was just like luck or anything like that. But the whole idea is it's supposed to be like a scientific experiment, one you might have done in like primary or high school. And we're going to go through an example PDSA later on. So we don't normally implement changes in practices and processes for no reason. So it's important that we identify the rationale behind the changes that we have in mind. When planning for quality improvement activities, we should reflect and reflect and consider the following 3 questions. 1 being, what are we trying to accomplish with this? 2 being how we know and measure the proposed change being an improvement. And 3 is, what change can we make that leads to improvement? Once we reflect on those changes, we can decide on and then carry on the activity, whether it's in that cycle format, that PDSA cycle format, or just by writing the activity with its purpose solely in a QI register and noting that the results in the outcomes section if it's a small activity that has little to no additional steps. And that way you're still capturing the evidence, but it has, a reduced administrative burden. You can also plan and forecast for future quality improvement activities in what's called a quality improvement plan, which is available on our QI toolkit on Practice Assist. I don't have this in the slide, but it's quite similar document to the QI register, and it allows you to identify priority areas, brainstorm ideas that you want to test that will lead to an improvement in a certain health domain. Okay, so a clinical audit is an example of a quality improvement activity that you can document. And us nurses, we're good at undertaking audits. I'm sure we've done plenty of our audits in our time, but we don't always document the method or the success of the audit and the observations that we've made along the way. We usually just get the audit done and say we've achieved it and just document basic numbers. As a minimum, we should at least document audits that we're doing in a quality improvement register, which includes writing down the type of audit, your intention of the audit, and what your high-level results are. If you're testing out a new audit from scratch, it's better to document as a PDSA because you can write your whole audit protocol out in full and document any changes that you've made to the protocol along the way, as well as measure that success and then document observations while you for the duration of the test. Your audit protocol should list parameters of the people you're looking at. So, for example, Aboriginal patients, the age groups you're wanting to target, whether it's overdue versus due versus upcoming immunisations, whether you're targeting a specific disease group or immunisation class, and so on. It should also list all the columns that you will include in your audit spreadsheet so that your audit can be easily repeated by somebody else. And an important thing about an audit is not just about recalling patients in and getting them engaged in primary care. It's also a good opportunity to identify some common issues that you find in the documentation of, say, the immunisation process or the actual clinical process itself, the steps you follow in an immunisation appointment. And it's a good opportunity for you to document some results, find some trends that will lead to quality improvement activities. All right, so you would already know about the recalls and reminders function in your softwares, but there's also search functions within practice management software that might help you identify patients that may not have recalls and reminders in place. And you can easily create a search in most practice management software that helps you identify, say, Aboriginal patients in a particular age group with missing immunisations in their record and have not opted out and are not allergic to a vaccination. Search queries can help you identify patients that don't have immunisation recalls in place, but can keep in mind that without that proper clinical coding, some patients may be missed. And with data quality, things like the Aboriginal status being missing with certain patient records or absence, or there's missing data for like immunisations being administered in the practice or outside of the practice, they're things that you might notice when you're doing a search query. So we recommend that if you run reports and you notice there's a lot of data cleansing that needs to be done, you can reach out to your local QI coach who can help you through that process and create a PDSA for you. You'll find you can also use PrimarySense, software provided by WAFA, to help you with your clinical audits. Of note, I would say there are 3 reports you'd find useful for Aboriginal immunisations. I guess the audits around that, and they are the health assessment report, your child immunisation report, and the winter wellness report when it comes to flu season. I've got on the screen there the child immunisation report and what it looks like. It helps you, it separates the patients into like age groups. It identifies those that have received the vaccines versus those that are due now versus those that are 2 months overdue. It's all color-coded, and it helps you prioritize who you should recall first. You can filter by Aboriginal status and export those tables to Excel to work through. And with those reports, they can be turned into a clinical audit. We not only identify those that are overdue, but you can also identify reasons as to why those patients became overdue for the vaccine by reviewing the clinical notes, recall list, the number of attempted contacts made with that patient, and so on. I'm going to show you an example PDSA. It's only in slide format, but usually you document a PDSA in a document, and that's available again on a QI toolkit and Practice Assist. Here you can see we have that listed activity, and it's translated into a SMART goal. And SMART stands for specific, measurable, achievable, relevant, time restrained. A SMART goal may look like something like this. By a particular date or within a time period, we will audit and recall all active Aboriginal and children for their overdue immunisations. Of course, you can limit that SMART goal to something even more specific, like Aboriginal children between the ages of 0 and 4, something like that. And keep in mind, I didn't say audit, recall, and vaccinate all Aboriginal children, because like there's some situations where there'll be refusal of immunisation. So we shouldn't put that into the goal. And then you can see here, I've listed some measures. Measures are just statements of ways of measuring the success of your quality improvement activity. It's important that you measure baseline data when you're starting your activity, knowing what you've got to start with, and then also measuring at the end of your activity as well, as you can see with those 3 measures listed. Yeah, the do section is pretty straightforward. It's just a step-by-step process of how you're going to undertake the activity. You can see I'm very explicit in how I write the protocol, because you want to make sure that any staff or practice or clinical staff member that takes on this audit knows exactly how to set up this audit step by step. If you have to change the process as you go, rather than deleting the steps that you initially wrote up, what I would do is write up the revised process in that do section after that initial process you've started, and document that you've changed the process as an observation in your study section to show that, you know, you've actually started with a process, but then it didn't actually really work as you were going through that activity, that QI activity, and that you've had to change it significantly. That's an observation in itself. The study section is pretty straightforward as well. It's your time for reflection, both of what was happening during the audit and what's happened after the audit's been finished. And you can see I put some generic prompt questions in there, like, did you achieve your SMART goal? Was it easy or difficult to implement the audit? Did it have little or great impact to the whole practice? Whether or not you've adjusted it, did you receive feedback from patients and staff? And then the act section is where you decide on how you're going to proceed with this audit in future, which is something that you shouldn't just make these decisions on a whim. You should be using your observations to guide your final decision. So is this going to be an audit that you're going to do regularly? Therefore, are you going to adopt this on a larger scale? Is this an audit that you're going to have to adjust and redo with different parameters? Are you going to have to change the method? So are you going to adapt this activity? Or are you going to abandon this audit or activity altogether because it's just too difficult, had no impact, it was actually detrimental to the service? And that is a PDSA for you in summary. But with, again, a QI coach is going to help you design a PDSA, or even use a different quality improvement activity template if need be. So another way you can opportunistically provide Aboriginal patients due or overdue immunisations is through a 715 health check. And 715 health checks can be billed for every 9 months. So what I'd recommend is putting in a recall maybe every 9 months or 9 months and 10 days, rather than a recall every 12 months. What you want to also do is ensure that checking the patient's AIR record for immunisations done elsewhere is part of the process of doing a 715 health check for a patient. And if you don't already know, there are really good 715 health check templates available through RACGP, which you can upload into your practice management software. As you can see in the slide here, this is the health assessments report through Primary Sense. And it helps you find who's due a 715 health check at your practice and who's got an upcoming appointment booked in. So you can flag those patients in the appointment notes and have that patient booked in with the nurse beforehand to complete part of the 715 health check. But just keep in mind that this report and other reports through Primary Sense, they don't look at PROTA data and MDS billing done elsewhere. So it only looks at your practice data. So you have to check through PROTA if the patient has had their 715 health check billed elsewhere. I've just provided a page of links. Highly recommend that you look through each of those. In particular, that third point from NACCHO and RACGP, the good practice tables, they give you the 5 steps to support to have culturally responsive healthcare in your general practice. And it gives you a bunch of ideas of activities you can do and how it aligns with each of the RACGP accreditation standards. I highly recommend looking at that link. And I've just made a list of some other quality improvement activities you can do. Feel free to look through this at your own time. And lastly, I just want to touch on health promotion. People might not realize health promotion is absolutely a quality improvement activity. You're working on improving patient outcomes by promoting health, by promoting engagement and access to the service. And yeah, so with that, patient feedback is absolutely a valid way of measuring success. It's called a qualitative measurement. So it's absolutely valid to use patient feedback to guide understanding whether or not this particular activity has led to success, has led to an improvement. And here's some examples as well, like having posters up and brochures and videos and health promotion tables and health promotion months. So you can read that in your own time. I'd just like to touch on lastly that we have quality improvement coaches all across WA working at WAFA. And our work is to help you embed quality improvement culture at your practice, assist you with helping setting you up with the quality improvement activity. We can also help you generate quality improvement ideas in your area of priority. And we can provide you face-to-face or virtual support. So if you don't know who your local QI coach is, just email our generic email, qi@wafa.org.au, and the QI coach for your area will be in touch with you to provide prompt support. Thank you.